Good evening, everyone. I welcome you all on behalf of Yashoda Hospitals for this program of shared learning. I'm Dr. Santosh Chandaka, Consultant Emergency Physician, Yashoda Hospital, Secunderabad. Today, as a part of our journal club, we are going to discuss a few clinically significant trials on PTE. Recently, we had a case, 29-year-old male patient presented with history of syncope. On evaluation, we found that he had elevated D-dimer levels and RARV dysfunction. On evaluation and doing CTPA, we found that he had a significant pulmonary thromboembolism. With this, why I'm telling is this, because we recently found that there is increase in diagnosis of number of cases of PTE in patients with acute exacerbations of COPD. Regarding this, Dr. Numana will discuss. And of all presentations, syncope is a very rare presentation for PTE. And regarding this PESIT trial, Dr. Vengappa will discuss. And we also know how to manage PTE. There are initially we had confusion whether to go initial opt for thrombolysis or catheter thrombolysis. Regarding this, Dr. Athira will discuss regarding CANARY Trial. So I now request Dr. Vengappa to continue with PESIT Trial. Yeah. Okay. PESIT trial is the trial where we discuss prevalence of pulmonary embolism in patients who are admitted hospitalized with complaints of syncope. And this trial, which was done, shows that 1 in every 6 patients who are admitted to hospital with syncope were diagnosed to have significant PE. So this trial is very significant. Along with that, we are discussing there in a recent trial published in September of this year that there is an increased risk of pulmonary embolism in patients with COPD, and we usually find that in COPD patients, RARV dilatation will be there, and we find that PAH will be there. And in these patients, diagnosis of CTPA is a bit tricky. So diagnosis of PT is a bit tricky. In these patients, there is a significant evidence to show that when the infection exacerbation is there, that we can go directly for CTPA, and this we are going to discuss in which is public. This we are going to discuss with evidence with a trial which is published recently in 2023. And CANARY trial, it's a very significant trial, but it couldn't be completed because of COVID. But the data which shows that there is significant what is the significance of catheter-directed catheter-directed thrombolysis compared to direct thrombolysis in patients with significant PTE. So I think these studies are very important in our regular clinical practice. So Vengappa, are you here? Or else we'll do one thing. We'll proceed with CANARY trial. We will proceed with acute risk of PT in COPD patients by Dr. Numana. Dr. Numana, hi, welcome. Dr. Numana is from Yashoda Hospital, Somajiguda. She is a resident of emergency medicine. Dr. Numana, can you discuss regarding the risk of pulmonary thromboembolism in patients with acute exacerbations of COPD?
Hi, sir. Good evening.
Hi.
Good evening, everyone. So coming to the discussion. So I am about to discuss regarding the characteristics of venous thrombus embolism in patients with acute exacerbation of COPD. There was a prospective multi-center study regarding it. The prevalence of VT in patients with COPD is higher than in patients without COPD. Owing to this similarity of clinical symptoms between pulmonary embolism and acute exacerbation of COPD, pulmonary embolism is likely to be overlooked or underdiagnosed in patients with acute exacerbation of COPD. The aim of the study was to investigate the prevalence, risk factors, clinical characteristics, and prognostic impact of venous thromboembolism in patients with acute exacerbation of COPD. So coming to the introduction part, COPD is third leading cause of death in the worldwide. COPD patients may have frequent episodes of exacerbations. So we find in our ERs many patients coming with breathlessness, dyspnea, chest pains, sweatings, and all. So these all constitute this part of acute exacerbations of COPD. Most cases of exacerbations, they are caused by infection or air pollution, but the exact cause of this exacerbation, it remains unknown in about 30% of the cases. Patients with COPD reportedly have twice the risk of developing thromboembolism than those without the patients of COPD, without the history of COPD. So, as pulmonary embolism manifestations may be similar to acute exacerbation of COPD, it is often difficult to distinguish between these two conditions, like pulmonary embolism, VTE, acute exacerbation of COPD. Thus, the diagnosis of pulmonary embolism based on clinical suspicion alone, it is not accurate enough. We have to go for few investigations, labs and all to exactly diagnose the diagnosis of pulmonary embolism. COPD patients tend to have a higher average age and they are more likely to have additional diseases than those without COPD. As their immunity is low, they'll have more additional diseases. If VTE is missed, it may cause adverse consequences and poor diagnosis. So, a recent meta-analysis found that the mortality of patients with VTE was higher than those without VTE, and the prevalence of VTE in studies where CTPA was performed was significantly higher, and where CTPA was not performed, it was missed. The diagnosis was missed. However, the meta-analysis only included a few studies with patients in whom CTPA was performed, and the sample size was relatively small, and it was only reported on the mortality during hospitalization or within 3 months after discharge. There were few studies on long-term prognosis of patients with COPD combined with venous thromboembolism. Therefore, the objectives this study were to assess the prevalence of VTE in a large cohort of patients with acute exacerbation of COPD who underwent CTPA. In addition, the effect of VTE on prognosis was evaluated in terms of length of hospital stay and 1-year mortality of the patients. A multi-center prospective cohort study was done. It was done for around 4 years in around 11 research centers. Data on the baseline characteristics, VTE, related risk factors, clinical symptoms, laboratory examination results, CTPA, that is computed tomography pulmonary angiography, and lower limb venous ultrasound of acute exacerbation of COPD patients was collected. So they were followed up for 1 year and prognosis was also dealt with. Coming to the inclusion criteria of this study, it is the age greater than 40 years, first thing, and COPD was diagnosed according to the criteria of 2016 Global Initiative for COPD, that is GOLD guidelines. Pulmonary function test showing the ratio of forced expiratory volume in the first second of expiration to forced vital capacity, which was less than 70% after post bronchodilator use, and that was confirmed by a senior physician. And the other point was patients hospitalized for acute exacerbation of COPD, acutely worsening respiratory symptoms of COPD were defined as a sustained worsening of patients' baseline symptoms like dyspnea, cough, sputum beyond normal variation, and they were requiring treatment modifications. So that was the inclusion criteria. And coming to the exclusion criteria, patients with COPD hospitalized for other conditions, so they were excluded. And contraindications for undergoing CTPA: active malignant tumors, anticoagulant treatment before the admission, pneumothorax at admission, whose life expectancy was less than 3 months, and who were unable to give a written informed consent. The procedures performed were baseline characteristics of the patient, including age, sex, height, weight, BMI, smoking status, were all collected at admission. There were clinical evaluations were done for all the participants, including the medical history inquiry, physical examination, and physician in charge, and ultimately confirmed by the senior physician. So the concomitant diseases with the participants were having, which were the risk factors for VT, which were including the bedridden state for more than 3 days, surgery or fractures in the past 3 months, oral contraceptive use, deep vein puncture in 1 month, hormone replacement therapy, diuretics treatment, and history of VTE. Coming to the clinical symptoms and clinical signs of the patient, they were recorded. The clinical symptoms and signs included chest distress, dyspnea, syncope, cough, sputum, productive cough, fever, hemoptysis, palpitations, lower limb swellings, skin pigmentation, temperature, pulse, respiratory rates, blood pressures. On auscultation, we checked for rhonchi or moist crackles, varicose veins in other patients, edema in the lower extremities. So pulmonary embolism probability score of Wells score and revised Geneva score are also recorded. There are two scores, Wells score as well as revised Geneva score. Wells score is a risk score interpretation for the probability of DVT. In this score, there are points. So if the point ranges from greater than 3 points or equal to 3, there was a high risk of the patient having DVT. If the score ranges from 1 or 2 points, it was a moderate risk, and less than 1 point, it was considered low risk. So the clinical features included were the active cancer, patient with an active cancer malignancy and paralysis, paresis, or immobilization of the lower extremities, the patient who was bedridden for greater than 3 days or because of a surgery, which was done within 1 month. If there was localized tenderness along distribution of the deep veins, if the entire leg was swollen, unilateral calf swelling of greater than 3 centimeters, 10 centimeters below tibial tuberosity. If there was edema, if there are collateral superficial veins, alternative diagnosis as likely as or more likely than DVT, prior history of DVT or pulmonary embolism. Each was given 1 point each, and the score was calculated in every patient. And coming to the other score, which is revised and simplified Geneva score, RGS, which was for pulmonary embolism. This score was total score of 0 to 3. It indicated low probability. As it goes higher, it indicates more probability. Coming to a 4 of 10, it indicates moderate, and score of greater than 10, it indicated high probability of pulmonary embolism. What all points we checked in this score were age greater than 65 years, if there was any previous venous thromboembolism, if there was any surgery, and if there was active malignancy and unilateral leg pain, hemoptysis, pain in the lower limb, deep vein palpation with unilateral leg edema, if there was heart rate tachycardia greater than 95 beats per minute or 75 to 94 beats per minute. Each was given a probable score of 2 or 3, and then the whole score was calculated. Score of less than or equal to 4, it indicates that pulmonary embolism is unlikely. So laboratory results were taken within 24 hours of admission, which were included CBP, PTINR, APTT, fibrinogen, D-dimer, ALT, AST, creatinine, NT-proBNP, ABG, cholesterol, triglycerides, and glucose. All patients underwent CTPA, ECG, lower limb venous Doppler, 2D echo within 48 hours. The diagnostic criteria for pulmonary embolism by CTPA were as follows. What we checked in CTPA was failure of the contrast material to fill the entire lumen. The artery might be enlarged as compared to the other similar arteries. There might be a partial filling defect surrounded by contrast material on a cross-sectional image. The contrast material between the central filling defect. So this was by CTPA, and ultrasound criteria for lower limb DVT were non-compressibility or incomplete compressibility of the vein in the horizontal axis. Along some patients had a previous clinical diagnosis of COPD or were treated for COPD. A spirometry examination was performed when the patient was relatively stable. So the patients who were confirmed VTE, who had confirmed VTE, anticoagulation was administered, and the patients were followed about 3, 6, and 12 months period. During the follow-up period, the patients reported to the study center immediately if any symptoms or signs indicating thromboembolism or bleeding or acute exacerbation of COPD was observed. At the end of the follow-up, all included patients were interviewed by the physicians through structured questionnaires or telephone interviews. All the events that occurred after discharge were noted, and the reason for readmission was determined. Results of this study were almost 1,580 patients were included in the study. So the mean age of patients was 70 years basically, and 195 patients were females. The prevalence of VTE was around 24.5%, which constituted of 387 patients of the 1,580 patients. And pulmonary embolism was a little low, which was 16.8%, that is 266 persons. VTE patients were older in age and they had higher BMI. They had a longer course of COPD than non-VTE patients. The history of VTE, cor pulmonale, less purulent sputum, increased respiratory rate, higher D-dimer, higher NT-proBNP to BNP were independently associated with VTE in hospitalized patients with acute exacerbation of COPD. The mortality at 1 year was higher in patients with VTE than patients without VTE. There was no significant difference in the prognosis of patients with pulmonary embolism in segmental, subsegmental arteries or in main pulmonary or lobar arteries. So this is a table which is showing us the flowchart of patients hospitalized with acute exacerbation of COPD. There were almost 1,711 patients hospitalized with COPD and acute exacerbation were assessed for eligibility. In these patients, 1,580 patients were included. Out of that 1,580 patients, CTPA, Doppler, ultrasound of lower limbs and ECG was done. 1,193 acute exacerbation of COPD without VTE. And 387 patients had VTE. So coming to VTE patients, in that VTE 387, 180 were found to have only PE, pulmonary embolism, 86 patients found to have PE and DVT both, and 121 had only DVT. So 28 patients lost the follow-up and 359 completed the follow-up. So this is according to the Wells criteria and the Geneva score, depending on the localization of the thrombi on CTPA and Doppler ultrasonography of lower limbs. So prevalence of VTE was around 24.5% as discussed earlier. Wells criteria, it showed 7.4% of low probability, 38% of moderate probability and 73% of high probability. So these patients were confirmed to have PE. But according to Geneva score, only 11% had low probability, 20% had moderate probability, and 50% of high probability were confirmed to have pulmonary embolism. The symptoms like cough, purulent sputum, bronchi, they are more prominent in patients without VTE. Chest distress, chest pain, higher respiratory rate, moist tracheals were prominent in patients with VTE. VTE patients had different symptoms than compared to patients without VTE. Levels of D-dimers, pH, NT-proBNP and BNP ratios, PTA, APTT, higher in patients with VTE than without VTE. The level of HB was lower in patients with VTE. So this is a graph which is showing us the analysis of this data. So coming to discussion, this study showed that 67.7% patients with acute exacerbation of COPD had PE in the absence of DVT. In the presence of VTE, if the presence of VTE is determined by only lower limb venous ultrasonography, 46.5% patients with VTE may be missed. A study found that the location of thrombus in patients with COPD and pulmonary tract infection were mostly in the segmental and subsegmental arteries. A study which showed that among 266 patients with pulmonary embolism, 100 had thrombus located in segmental or subsegmental arteries. Patients with segmental or subsegmental pulmonary embolism are less likely to be distinguished from acute exacerbation of COPD because the clinical symptoms were less pronounced. A systematic CTPA during COPD exacerbation could not only assist in identifying more unsuspected PE cases, but also determine the location of PE. Therefore, the implementation of CTPA for patients with acute exacerbation of COPD is necessary. Regarding the clinical characteristics, patients with purulent sputum, they showed lower incidence of VTE. Other studies also showed that increased purulent sputum was indicator of absence of PE, indicating that acute exacerbation of COPD was caused by bronchial or pulmonary infection, but not PE. It might be an infection, but not PE. The increased respiratory rate and lower PaCO2 levels were associated with pulmonary embolism. Studies also showed that lower PaCO2 level was associated with pulmonary embolism in acute exacerbation of COPD patients due to increased respiratory rate in patients with pulmonary embolism, resulting in excessive exhalation of CO2 that is a predictive factor for the prevalence of venous thromboembolism in patients with acute exacerbation of COPD. Previous studies and this study also demonstrated that the history of VTE was an independent risk factor for VTE. Most patients with carpal are complicated with heart failure, and this study showed that carpal was independent risk factor for VTE, consistent with previous studies. PT was an independent factor in multivariate analysis conducted in this study. The underlying mechanism is likely the large amount of plasminogen that will be consumed during the procedure of VTE, resulting in hyperfibrinolysis and increasing the PT value. Why PT was the independent factor? This was the mechanism underlying that. However, the study showed that the median value of PT was still in the normal range in both the VTE group and the non-VTE group. So its clinical significance remains to be discussed. BNP is mainly synthesized and secreted by the ventricular myocytes. When PE occurs, increased right ventricular afterload and ventricular wall dilatation leads to release of BNP. Result shows that NT-proBNP or BNP, it was an independent predictive factor for VTE in COPD patients, consistent with other studies. All the above clinical features can help us accurately identify VTE in patients with acute exacerbation of COPD. In our study, the 1-year mortality among patients with venous thromboembolism was higher and length of hospitalization was longer among patients without VTE. We further analyzed the survival of patients with PE at different locations. The result showed that mortality of patients with PE in segmental and subsegmental artery was around 12%, and mortality of patients with PE in mean lung arteries or lobar arteries was 16%. But both groups had significantly poorer survival than those without PE. Therefore, timely detection of PE in patients with COPD and performing active treatment is very important. Currently, there is a controversy over whether to adopt an active diagnosis to screen for PE in patients with acute exacerbation of COPD. Proposal include the use of in all the patients with acute exacerbation of COPD and fairly judicious use of CTPA. Those who opt for a more restricted approach point out that universal screening for all patients increases radiation exposure, the risk of kidney disease induced by contrast, and increases the economic burden of patients. However, if CTPA was not performed, patients with pulmonary embolism in the segmental or subsegmental artery will be underdiagnosed. Accordingly, anticoagulant therapy is not administered to this subset of patients, which will lead to worse prognosis. Coming to the conclusion, VT is common in COPD patients and is associated with poor prognosis. Patients with pulmonary embolism at different locations had poorer prognosis than patients without pulmonary embolism, and it is necessary to have an active screening strategy for VTE in acute exacerbation of COPD patients with risk factors. Thank you.
That was very good presentation, Dr. Numana. So, what do you advise from this study? So, do you say that every patient with PTE, every patient with acute exacerbation of COPD should get a CTPA done?
Sir, depending on the clinical features like purulent sputum, chest distress, dyspnea, and all, considering that we need to take CTPA into consideration, sir, mostly.
Okay, fine. So, do you think that a patient in COPD exacerbation without VTE also we have to go for PTE screening? Without venous thrombus, without DVT also, do we have to go for PTE screening?
Yes, sir, might be because it might be an incidental finding.
Yeah, definitely. Maybe without symptoms also. From the study, what you have presented, what they have shown is that even segmental, subsegmental artery occlusion also mortality is high. So definitely, I think this is a clinically significant study. Thank you, Dr. Numana. You have done a wonderful job. So now we will discuss the risk of PT in patients with syncope who have presented to hospital with syncope. What is the risk? Dr. Vengappa Naidu from Yashoda Hospital, Secunderabad will present this.
Good evening, all. Today, topic of so it is to study the prevalence of pulmonary embolism among patients hospitalized with syncope. Yeah. Syncope is defined as transient loss of consciousness, rapid onset, short duration, and spontaneous recovery caused by cerebral hypoperfusion. So here we are studying the background is pulmonary embolism is an established cause of syncope, but most current diagnostic guidelines for workup of syncope pay little attention to PE. In patients admitted to the hospital for syncope, PE is often not considered and may be missed. The most common causes of syncope are vasovagal syncope, orthostatic hypotension, situational syncope, arrhythmias, and these are all cardiovascular causes. Neural causes are epileptic seizure, stroke, head trauma. So the study question is, what is the prevalence of PE in patients hospitalized for their first episode of syncope? So this is a cross-sectional study designed to determine prevalence of PE in patients older than 18 admitted for first episode of syncope. It is a multi-center study done at 11 Italian hospitals, 2 academic and 9 non-academic. No randomization given. It is a cross-sectional study. Funding was done by research funding from University of Padua, Italian university, founded in 1222. Inclusion criteria are 18 years old or older, hospitalized for first episode of syncope. Exclusion criteria are previous episodes of syncope, less than 18 years old, not admitted, on anticoagulation, pregnant females, and patients on hormone replacement therapy. And the neural causes such as stroke, head trauma, and epileptic seizure have been excluded. Patients, 2,584 patients presented to study centers, ED for syncope. 1876 were discharged from the ED and therefore excluded. 717 were admitted. 157 of admitted patients were excluded because 118 on anticoagulation, 35 had prior syncope, 4 declined to participate. 560 patients included in the study. Among them, the mean age was 76 plus or minus 14. 39.8% were male, 6% were obese. Does not give breakdown of comorbidities. As these patients are these patients similar to our patients? Hard to say without information or comorbidities. Probably older, less obese. What do they do? In all the patients included in the study, they have checked a D-dimer and calculated a Welch score, even when there was another potential etiology for syncope. So this is modified Welch score. the total score of 4 or lower indicates that pulmonary embolism is unlikely, and a score higher than 4 indicates that pulmonary embolism is likely. Clinical signs and or symptoms of DVT contains 3 points. Alternative diagnosis less likely than pulmonary embolism contains 3 points. Heart rate more than 100 beats per minute has 1.5. Immobilization or surgery in the previous 4 weeks has 1.5. Previous veno thromboembolism has 1.5. Hemoptysis has 1 point, and active cancer has 1 point. Among these, less than 4, P is unlikely. More than 4 indicates pulmonary embolism is likely. So if a D dimer negative and Well score was less than or equal to 4, P was considered to be ruled out. If D dimer positive and Well score was greater than 4, a CT scan, CTPA or ventilation perfusion scan was done to evaluate for PA. There was one patient who died before CT or ventilation perfusion scan could be done, and an autopsy was performed. In patients with PE, thrombotic burden was evaluated by a committee. So, presence or absence of PA. So 1867 were discharged, 822 had vasovagal syncope, 465 had situational syncope after urination or after a meal, 380 had drug-induced hypotension, 112 patients had volume depletion, 81 declined hospitalization. Among these, 717 patients were admitted to the hospital, 157 were excluded. In that 118 were receiving anticoagulation therapy, 82 had atrial fibrillation, 36 had other reasons, 35 had recurrent syncope, 4 declined to participate. 560 patients were included in the study, 330 had low pretest probability for pulmonary embolism and negative D-dimer assay, and 230 had high pretest probability for pulmonary embolism, positive D-dimer assay or both. 463 had pulmonary embolism ruled out, 97 had pulmonary embolism confirmed. So on a CTPA, we look for intraluminal filling defect, and the ventilation perfusion scan is performed in patients with renal impairment or patients allergic to contrast material. A ventilation perfusion scan can be done. In that, a segment shows 75% perfusion defect with mean age is 76 plus or minus 14. Median age is 80. So clinical features that we studied are for prodromal symptoms, 227 of all patients. Pulmonary embolism confirmed in 41 patients. Pulmonary embolism was ruled out in 186. Respiratory rate more than 20 patients. Tachypneic were 77, of which pulmonary embolism was confirmed in 44 and ruled out in 33. Heart rate of more than 100, tachycardia. Total number of patients studied were 107, of which 32 had pulmonary embolism confirmed and 75 had pulmonary embolism ruled out. Systolic BP of less than 110 were 141 of all patients. The pulmonary embolism was confirmed in 35 and pulmonary embolism was ruled out in 106. Clinical signs of DVT, total number of patients was 60, of which pulmonary embolism was confirmed in 39. Which is significant among all. Pulmonary embolism was ruled out in 21. So risk factors for venous thrombosis, prolonged immobility was studied in 38, of which 10 had pulmonary embolism confirmed and 28 had pulmonary embolism ruled out. A recent trauma or surgery, 27 patients, pulmonary embolism was confirmed in 7 and ruled out in 20. Active cancer, 65 patients of all patients were studied. In that, pulmonary embolism was confirmed in 19 and ruled out in 46. Infectious diseases, 49 patients. Pulmonary embolism was confirmed in 12 and ruled out in 37. Vasovagal syncope was identified in 86 patients, situational syncope in 51, and carotid sinus syncope in 12 patients. Hypotension due to autonomic failure was identified in 46 patients. drug-induced hypotension in 35 patients, and hypotension due to volume depletion in 31 patients. Arrhythmias were identified in 49 patients and structural disease in 45 patients. So the results are in 330 patients, PE was ruled out based on negative D-dimer and well score less than or equal to 4. 230 evaluated for PE, 135 had positive D-dimer only, 3 had well score more than 4 only, and 92 had both. 180 patients had CTPA, 49 had ventilation perfusion scan, 1 had autopsy. Among which 97 patients found to have PE, prevalence was 17.3% in the entire cohort. PE found in 52 of 205 patients with no alternative etiology for syncope. PE found in 45 of 355 patients with an alternative etiology for syncope. In 49 of 73 patients with PE on CT or autopsy, the most proximal location of PE was main pulmonary artery, right or left pulmonary artery, or lobar artery. In 12 of 24 patients with a PE on ventilation perfusion scan, the perfusion defect was larger than 25% of total lung area. 61 of 97 patients with PE had evidence of large PE. Tachypnea, tachycardia, hypotension, clinical signs and symptoms of DVT, history of venous thromboembolism, active cancer. 24 of 97 patients with PE had no clinical manifestations of PE. Follow-up, there was no follow-up. Limitations, no information or guidance on how PE was treated in patients where it was found. Other workup of syncope was not standardized, left to discretion of physicians, didn't include patients on anticoagulation or with prior history of syncope. Didn't include patients not admitted to the hospital. No information on provoked versus unprovoked. Limited by its design as a cross-sectional study, naturally raises questions it's not designed to answer. In what percentage, if any, was PE an incidental finding? What about the patients found to have small P's? How should they be treated? Outcomes? Should we check well score and D-dimer in every patient admitted with syncope? So if well score is more than 4 and D-dimer is positive, we better go for a CTPA. And basically in pulmonary embolism, if there is proximal, the proximal thrombus, we can see Westermarck sign, which shows proximal dilatation of arteries with distal narrowing on an X-ray. PE is prevalent in patients admitted for syncope and should be part of your differential for a patient admitted for syncope. In a patient admitted for first episode of syncope, a well score should be calculated and a D-dimer should at least be considered.
Yeah. Yes, Dr. Vengappa, that's a good presentation. So, from what he's saying that out of 2,500, almost 2,500 people who are studied, who presented with syncope, 700 were admitted to the hospital, and they found that out of the 700, 97 had syncope. So, do we check well score for all patients with syncope? I think from this study, I say better in every hospitalized, out of 797 means it's very significant number. So every hospitalized patient with syncope, better check well score. What do you say, Dr. Sangappa?
We should
check well score, sir, and we should check for DVT. And it's better we do a 2D echo and an ECG to confirm and come to a conclusion.
Yeah, that's a good presentation. Thank you, Dr. Vengappa. Yeah, now we discuss regarding how we manage the PTE patients. So we are very well known that we should start anticoagulation in these patients as soon as PT is diagnosed. Thrombolysis is preferred if patient is very unstable. Or so if in this unstable patient, until now what we follow is patient he is unstable and it is recurrent PT, we go for catheter directed PT thrombolysis. So do we go for catheter directed thrombolysis in every patient diagnosed with PT or not? So for this, Dr. Athira will discuss whether what is the significance of thrombolysis in patients with unstable PT. Dr. Athira?
Hi, sir.
Need sound which was
Good evening, sir. Hello, sir. Am I audible? Hello.
Yes, you are audible, ma'am.
Good evening, everyone. Now we'll discuss on the intervention part of the pulmonary embolism. The one trial that came up with the intervention part is the CANARY Trial. So from the previous two discussion, it was clear that the clinical manifestations of pulmonary embolism hello, sir.
Yeah, Dr. Athira, please continue. Continue regarding.
So from the previous two discussions, it was clear that there can be varied presentations for the pulmonary embolism. So it can be minor symptoms to obstructive shock or even sudden cardiac death can occur. So according to the 2019 European Society of Cardiology guidelines on acute pulmonary embolism, reperfusion therapy, preferably we use systemic thrombolysis for the hemodynamically unstable patients. Even when for normotensive patients, if the patient goes to hemodynamic decompensation or deterioration, then there we consider thrombolysis rather than anticoagulation. So usually we have that for low risk patients, we can go with early discharge or start on anticoagulation. For high risk patients, we can go with the thrombolysis part. For the intermediate risk patients, the topic is still under debate. What to give, whether to give with the anticoagulation or with the thrombolysis part. So first is the risk stratification part. Based on the risk stratification, the treatment part will be based. So first, if you are suspecting a patient with, if the patient was confirmed with acute pulmonary embolism, the next thing we have to see is that whether the patient have any hemodynamic instability. If there is any hemodynamic instability, then it is considered as high risk. Then we will go with the reperfusion treatment. Then if there is no hemodynamic instability, then we have to see for other things. That is, if there is any clinical signs of pulmonary embolism severity or any serious comorbidities. So pulmonary embolism severity, there is one scoring system, pulmonary embolism severity index score. So if the patient belongs to class 3 to 5 or simplified pulmonary embolism severity index is more than or equal to 1, then that is one criteria for hemodynamic for pulmonary embolism intermediate risk. Then we have to see whether there is any RV dysfunction on transthoracic echo or CTPA. If both these are present, then we have to see that perform the troponin test. If troponin test is positive with RV dysfunction, then we consider it as intermediate high risk. Then if the troponin test is negative, then it is taken as intermediate low risk. If nothing is there, neither that clinical signs of pulmonary embolism severity or serious comorbidity or RV dysfunction, neither of these are there, then it is taken as low risk. So in low risk if there is no other reasons for hospitalization or there is family or social support and easy access to medical care, then we can early discharge the patient and give home treatment. If anything, this is positive, then we can hospitalize the patient. So always the debate is based on the intermediate part. So intermediate high risk, how we have to treat. That was the discussion. So CANARY Trial shows some of the points that some of the treatment methods that we can choose for intermediate high risk pulmonary embolism. So this is the risk stratification that we can do in a pulmonary embolism case. So pulmonary embolism severity index, actually it has been validated to assess the 30 and 90-day mortality at post-pulmonary embolism. So in this index, the points that were included were age, male gender, 10 points were given, cancer, 30 points, heart failure, 10 points, chronic lung disease, 10 points, heart rate of more than 110 beats per minute, 20 points, systolic BP less than 100 mmHg, 30 points, respiratory rate more than or equal to 30 breaths per minute, 20 points, body temperature less than 36 degrees Celsius, 20 points, disorientation, lethargy, stupor, coma, 60 points, oxygen saturation on air less than or equal to 90%, 20 points. So based on this score calculation, class 1, that is score of less than or equal to 65 is considered as very low, that is 0% mortality. Class 2, 66 to 85 score is considered as low risk with 1% mortality. And class 3, 86 to 105 score is considered as intermediate risk with 3.5% mortality. And class 4, 106 to 125 high risk with 10.4% mortality. Class 5 is more than 125, score of more than 125, that is very high risk, 24.4% mortality. So in the CANARY trial, the research question was whether the catheter-directed thrombolysis plus anticoagulation improve the echocardiographic measures of RV to LV ratio in acute intermediate high-risk pulmonary embolism. So previously, many studies were done. So among the meta-analysis, this fibrinolytic therapy was associated with lower rates of all-cause mortality, but there is an increased risk of major bleedings and intracranial hemorrhage. So catheter-directed thrombolysis optimized the fibrinolytic drug delivery into the pulmonary artery and consequently require the required dose of the thrombolytic, which may translate to fewer bleeding events. In catheter-directed thrombolysis, we will administer the thrombolytic drug directly into the pulmonary arterial circulation, generally over 24 to 48 hours with the maximal dosage of thrombolytic. So in the prior observational studies and relatively small clinical trials of catheter-directed thrombolysis, potentially beneficial effects were observed and short-term metrics such as RV function. So many studies trials were done on the interventional therapies in the pulmonary embolism. So in 2014, PESIT trial and Ultima trial was there. In PESIT trial, it was systemic thrombolysis plus versus anticoagulation was done in intermediate risk pulmonary embolism. So, but in the systemic thrombolysis, in that PESIT trial, the study result was that there were hemodynamic benefit was there with the systemic thrombolysis, but there were bleeding risk was more. Then in the Ultima trial, the next trial that came with catheter-directed ultrasound-assisted thrombolysis versus anticoagulation. So in that, more beneficial, rather anticoagulation alone, anticoagulation monotherapy, better than the ultrasound-assisted thrombolysis. Then other studies like CETIL-2 study, in that also ultrasound-assisted thrombolysis in intermediate and high-risk pulmonary embolism. So in that also minimal bleeding risk events were there and RV recovery was good. Then came the optimized pulmonary embolism trial in 2018. That is ultrasound-assisted thrombolysis in intermediate risk pulmonary embolism. That also showed in that ultrasound-assisted thrombolysis, lower doses of thrombolytic drug was used. That also showed beneficial effects. In 2019 and 2020, thrombectomy, mechanical thrombectomy, use of mechanical thrombectomy in intermediate risk pulmonary embolism was done. Mechanical thrombectomy was found to be more beneficial rather than this anticoagulation alone. Then came the extract PE study and sunset PE study. Extract PE study was an aspiration thrombectomy study, and sunset was ultrasound versus catheter directed thrombolysis. So in both ultrasound catheter directed thrombolysis and ultrasound assisted thrombolysis and catheter directed thrombolysis, both have similar recovery, RV recovery and hemodynamic benefits. Then in 2022 came the CANARY trial, in that catheter directed thrombolysis plus anticoagulation versus anticoagulation monotherapy in intermediate risk pulmonary embolism. Then now the ongoing trials are the PITRAC trial, BETULA trial, HYPETO trial, PEERLESS trial, STRIKE pulmonary embolism trial, and CATH-PE trial. In these trials, actually, the studies are going based on the thrombolysis, ultrasound assisted thrombolysis versus catheter directed thrombolysis based and their dose of the thrombolytic drugs used and the duration for which the drug is used. These are the ongoing trials going on. In the CANARY trial, it was an open label, parallel group mass 10-point randomized clinical trial. It was done in 2 large cardiovascular centers in Tehran, Iran. It was done from December 22, 2018 to February 2nd, 2020. So the study population was adult patients presenting within 14 days from the symptom onset with acute intermediate high-risk pulmonary embolism. That intermediate high-risk pulmonary embolism, that is according to the latest classification of the European Society of Cardiology guidelines. Then simplified pulmonary embolism severity index score of 1 or more, and there is confirmed CTPA diagnosis of pulmonary embolism. These were the inclusion criteria. Patients more than or equal to 18 years with acute intermediate high-risk pulmonary embolism within 14 days of symptom onset, simplified PESI score more than or equal to 1, and CTPA confirmed diagnosis of pulmonary embolism. In the exclusion criteria, creatinine clearance less than or equal to 30 ml per minute, and there is any contraindication to fibrinolytic therapy, right heart thrombosis, terminal illness, and if there is a surgery within prior 2 weeks, or any allergic reaction to the study medications, and lack of withdrawal of the informed consent. So intervention group and control group were there. In the intervention group, a fixed dose of alteplase was given at the rate of 0.5 mg per hour, along with unfractionated heparin 500 units per hour for 24 hours for patients who were randomized into catheter-directed thrombolysis plus anticoagulation group. Then in the control group, anticoagulation monotherapy. In that, enoxaparin 1 mg per kg subcutaneously twice daily for 48 hours. So the outcomes that were assessed in that primary outcome was to assess the proportion of patients with RV-LV ratio greater than 0.9 at 3-month follow-up, which was assessed by the Imaging Core Laboratory. And the secondary outcomes were the proportion of patients with RV-LV ratio greater than 0.9 at 72 hours after randomization, and those with unrecovered RV function at 3-month follow-up, and all-cause mortality at 3 months. And the adverse events that noted were fatal bleeding, intracranial hemorrhage, major bleeding, any major bleeding, vascular access complication, or severe thrombocytopenia. So in this trial, 270 patients were assessed for eligibility, but in that 176 were excluded. Of the 176, 169 did not meet the eligibility criteria, and 7 declined to participate. So the remaining 94 patients were randomized. In that, 48 patients were assigned into the conventional catheter-directed thrombolysis and entered into the primary analysis. Of that, 2 did not accept on-site follow-up. So 46 participate in the 3-month echocardiographic follow-up. The other group where they received anticoagulation monotherapy, 46 people were randomized. Among that, 4 did not accept on-site follow-up and 3 died before the 3-month follow-up. So 39 participated in the 3-month echocardiographic follow-up in the control group. But for this study, actually, to get a power of 80%, for the study to be significant, actually a sample size of 144 was needed. but that much sample size was not there for this study. Then the categorical variables were analyzed using the chi-square or Fisher-Exact test. Continuous variables were analyzed with the t-test. And after completion of enrollment, but before analyzing the trial data, meta-analysis from the catheter-directed thrombolysis arms of prior randomized trials plus the current trial was assessed to assess the pooled relative frequency of the bleeding events. So the result of the study was that primary outcome, that RV-LV ratio, it was greater than 0.9 at 3-month follow-up in 4.3% of catheter-directed group and 12.8% of the anticoagulation group has an RV-LV ratio greater than 0.9 at 3-month follow-up. And in the secondary outcomes, 4.3% of the catheter-directed group had RV-LV ratio greater than 0.9 at 72 hours. And 17.3% of the anticoagulation group had the RV-LV ratio greater than 0.9 at 72 hours after randomization. And the safety outcome, major bleeding, or 2.1% of the catheter-directed group had major bleeding events. So in the study outcomes, you can see that that primary outcome, 2 patients had 4.3% patient had 3-month echocardiographic RV-LV ratio more than 12.8% had RV-LV ratio more than 0.9 in the anticoagulation group. Then in the safety outcomes, it is obvious that 1 patient had BARC type 3 or 5. BARC scoring system is based on the bleeding events. That is type 3 or 5 means the patient will be having clinically significant bleeding events. Then clinically relevant non-major bleeding events were seen in there were 3 people who had clinically relevant non-major bleeding in the first group, that is conventional catheter-directed thrombolysis plus anticoagulation group. So then the subgroup analysis was done. In the subgroup analysis for the age, sex, BMI, diabetes, hypertension, CAD, and heart rate, all it favors the intervention. There were no significant specified subgroup analysis. There was no intervention part was favored more. These were the baseline characteristics in the patients who completed the 3-month follow-up. So in this, we can see that almost in both the groups, the baseline characteristics were almost similar. Only in that the female representation was less in this group. So from this trial, there were no statistically significant difference in the proportion of patients with RV-LV ratio more than 0.9 in the catheter-directed thrombolysis group versus anticoagulation monotherapy group at 3-month follow-up. But there was a significant decrease in the proportion of patients with RV-LV ratio more than 0.9 at 72 hours after randomization. And catheter-directed thrombolysis was also associated with more echocardiographic RV recovery at 3-month follow-up when compared to anticoagulation monotherapy. The limitations of the study was, 1, the study was discontinued in view of COVID pandemic. Then the assessment of 6-minute walk test was performed in only 1 center. Actually, 2 cardiovascular centers were there. Only in 1 center that test was assessed. And at the time of analysis, women were underrepresented in the study. Then only 2 patients in the study group, only 2 patients had prior history of PTE. So the relative frequency of previously undiagnosed chronic thromboembolic pulmonary hypertension in these patients were uncertain. Then the assigned dose of alteplase in the current study was based on the available evidence at the time of trial design. Now, actually, so many trials are ongoing, whether the low-dose thrombolytic drugs can be administered to reduce the thrombus burden. So this trial when this study was done, high-dose thrombolytic drugs was delivered for this trial. So the summary from this trial was that for intermediate high-risk pulmonary embolism, that thrombolysis plus anticoagulation was more beneficial compared to the anticoagulation monotherapy. Even though this study was statistically it is not significant, but the results showed that it is more beneficial when considering intermediate high risk pulmonary embolism. So many trials are on going on based on this topic.
Yeah, hi, Dr. Athira. That was a good presentation. Actually, why we chose CANARY Trial is because this was a trial which showed that we, after using catheter-directed thrombolysis and anticoagulation versus monotherapy alone, there is a significant change. But this study as such is not significant, but it was a basis for many more coming trials. So to further research. So I thought CANARY Trial, why I chose is because in many patients we are confused whether to start thrombolysis in ER itself or we have to go for catheter thrombolysis. So usually in patients with recurrent PE or where their symptoms are not improved after thrombolysis also, we choose catheter thrombolysis or thrombus aspiration. So what do you say? What is your take on this study, Dr. Athira?
Better to go with the catheter-directed thrombolysis because it have more beneficial effects. And also now so many trials are going on based when we see the adverse effect that the bleeding risk. So many trials are going on with low dose thrombolytic drugs. We can reduce the thrombus burden.
Yes.
So rather than going for systemic thrombolysis, catheter-directed thrombolysis may have a beneficial effect on it.
So what do you say in hemodynamically unstable patients? So do you take this for hemodynamically unstable patients also?
Unstable patients, actually, according to the guidelines, systemic reperfusion therapy is advised now. But there are trials like TRACT and all. There are studies which going with high risk, with massive pulmonary embolism, that catheter-directed thrombolysis versus systemic thrombolytic therapy is trials are
In
going.
hemodynamically unstable patients, even after we tried thrombolysis, if there is no improvement, I think better to go for invasive
Yes.
procedures. Yeah. Thank you, Dr. Athira. Yeah.
Thank you.
With that, we conclude our session. Yeah, I thank Dr. Srinath, Dr. Vinith for giving me this opportunity. I thank all Yashoda hospitals for giving me this opportunity. Thank you, Dr. Vengappa. Thank you, Dr. Athira. Thank you, Dr. Numana. Thank you.